Hello everyone, thank you for joining UCAP and hope you are keeping well. I'm Dr. Adila Mokhtar, a consultant clinical oncologist. In this presentation, I will be covering the subsequent line systemic therapy in advanced urothelial carcinoma. This slide shows the current landscape in advanced urothelial cancer, and in this presentation, we'll be focusing on the second and third line treatment options. The ESMO guideline has recommended some new treatments as the second or third line options. These include rechallenging with platinum-based chemotherapy for patients who didn't have chemotherapy in the first line. Other than that, single-agent enfortumab vedotin can be used following progression with platinum-based chemotherapy. Erdafitinib is one of the new treatments that can be considered in the subsequent line of treatments. Shortly in my lecture, I will go through the evidence base for all treatment available. Similarly to ESMO guideline, EAU and NCCN has also recommended some treatment for the second and third line in the management of advanced urothelial cancer, which we will go through the evidence base for each options. How does the choice of first-line therapy in advanced urothelial cancer impact subsequent treatment options? As more treatments become available in oncology, appropriate sequencing of therapies becomes increasingly complex, and there are several factors that can help to determine our decision-making. Before initiating treatment, we need to look at various factors, including the characteristic of the tumor, whether it's high risk of refractory or relapse, patient's perspective, so we can best manage these patients. While more evidence is needed to determine optimal treatment sequencing, an ongoing real-world study shows promising survival benefits with the use of a second-line antibody drug conjugate. There are several factors that should be considered before deciding on treatment options. These include the efficacy of the drug using evidence-based, the treatment duration, safety and tolerability in short and long term. Patients' backgrounds such as performance status and comorbidity are also important, and not to forget patients' preference, cost, and access of the drugs. A biomarker can be predictive, prognostic, or both. Predictive biomarkers are associated with outcomes in the context of specific treatments, while prognostic biomarkers are associated with outcomes irrespective of treatment. This treatment-dependent distinction implies that a biomarker's classification may change as disease treatment landscape evolves. Today's prognostic markers may be tomorrow's drug targets. This slide is to discuss the biomarkers that can guide treatment selection that can be used in advanced urothelial carcinoma management. The FGFR proteins comprise a family of 4 transmembrane receptor tyrosine kinases, FGFR1 to 4, with roles in cellular proliferation, differentiation, apoptosis, migration, and angiogenesis. FGFR3 alterations are observed in approximately 81% of non-invasive urothelial carcinoma and up to 54% of invasive urothelial carcinoma. Erdafitinib has been approved for use in previously treated advanced urothelial carcinoma with a susceptible FGF2 or 3 alterations. Multiple ADC targeting HER2 are also being tested in urothelial carcinoma. Disitamab vedotin, a HER2 antibody conjugated with MMAE, demonstrated promising responses for advanced urothelial carcinoma after at least one prior line of therapy. Trastuzumab deruxtecan, an ADC pairing trastuzumab with a topoisomerase 1 inhibitor, is an ongoing phase 1b trial which has promising results. Meta-analysis of prospective trials show that overall PD-L1 expression is associated with radiographic response to immune checkpoint inhibitors in AUC patients. However, even among PD-L1 positive patients, single-agent immune checkpoint inhibitors response rates are low and variable across randomized trials ranging from 20 to 40%. Enfortumab vedotin is an ADC targeting Nectin-4, a transmembrane protein involved in cellular adhesion and upregulated in EUC with limited expression in benign tissue. Despite the targeted nature of EV, Nectin-4 is not currently utilized as a biomarker in patient selection. The EV-101 phase 1 trial initially required Nectin-4 expression for inclusion, but the protocol was later amended to remove that requirement because nearly all skin tumors express Nectin-4 at high levels. Subsequently, the pivotal phase 3 EV-301 trial demonstrated an overall survival benefit for EV in a biomarker unselected population. THOR study is a phase 3 trial of Edafitinib as compared with chemotherapy in patients with advanced urothelial carcinoma with susceptible FGFR2 or 3 alterations who had progressed after one or two previous treatments that included an anti-PD-1 or anti-PD-L1. Patients were randomly assigned in 1-to-1 ratio to receive Edafitinib or the investigator's choice of chemotherapy. The primary endpoint was overall survival and secondary endpoint were progression-free survival, response rate, and safety. Based on the THOR trial, a total of 266 patients underwent randomization, 136 to the Edafitinib group and 130 to the chemotherapy group. The median follow-up was 15.9 months. The median overall survival was significantly longer with Edafitinib than chemotherapy, 12.1 months versus 7.8 months. The median progression-free survival was also longer with Edafitinib compared to with chemotherapy, with 5.6 months versus 2.7 months. Edafitinib significantly extended overall survival in FGFR alteration advanced metastatic urothelial carcinoma after treatment with PD-L1 with median overall survival of 1 year and provided a 36% reduction in risk of death compared to chemotherapy. The study has also shown that response rate in Edafitinib group is higher compared to chemotherapy, 45.6% versus 11.5%. This table is to summarize the safety profile in using Edafitinib. Overall, the incidence of grade 3 or 4 treatment-related adverse events was similar in the two groups, 45.9% in the Edafitinib group and 46.4% in the chemotherapy group. The most common side effects with Edafitinib are hyperphosphatemia, diarrhea, and stomatitis. It has shown that bone marrow suppression incidents are less in the Edafitinib group as compared to chemotherapy. Most side effects with Edafitinib are manageable with dose modifications and supportive care. Treatment-related adverse events that led to death and discontinuation due to treatment-related adverse effects are lower in the Edafitinib group. EV-301 study is a global, open-label, phase 3 trial of enfortumab vedotin for the treatment of patients with advanced urothelial carcinoma who had previously received platinum-containing chemotherapy and had disease progression during or after treatment with a PD-1 or PD-L1 inhibitor. Patients were randomly assigned in a 1-to-1 ratio to receive enfortumab vedotin or investigator-chosen chemotherapy administered on day 1 of 21-day cycle. The primary endpoint was overall survival and secondary endpoint is progression-free survival, overall response rate, and safety profile. EV-301 study has shown overall survival was longer in the enfortumab vedotin group than in the chemotherapy group, with a median overall survival of 12.8 versus 8.9 months with a hazard ratio of 0.7. Table is to demonstrate the most common treatment-related events specific to enfortumab vedotin, including neuropathy, skin reactions, and hyperglycemia. Mostly were generally mild to moderate and manageable. 12% of patients who had EV had to be discontinued and majority were due to peripheral neuropathy. Keynote 045 is an open-label, international phase 3 trial with advanced urothelial carcinoma that recurred or progressed after platinum-based chemotherapy to receive pembrolizumab at dose of 200 milligrams every 3 weeks or the investigator's choice of chemotherapy. The primary endpoints were overall survival and progression-free survival, which were assessed among all patients and among patients who had a tumor PD-1 ligand PD-L1 combined positive score, the percentage of PD-L1 expressing tumor and infiltrating immune cells relative to the total number of tumor cells. As a result, pembrolizumab was associated with a significantly longer overall survival by approximately 3 months and with a lower rate of treatment-related adverse events than chemotherapy. There was no significant between group difference in the duration of progression-free survival in the total population or among patients who had a tumor PD-L1 combined positive score of 10% or more. Tropics-04 is a phase 3 global open-label trial which randomized 711 patients with advanced urothelial carcinoma who had progressed on or after platinum-based chemotherapy and anti-PD-1 therapy. They were randomized to either receive sacituzumab govitecan 10 milligrams per kilogram on day 1 and 8 every 21 days or platinum-based chemotherapy. After a median follow-up of 9.2 months, while a trend toward favorable overall survival with sacituzumab govitecan was observed, the primary endpoint of improved overall survival with the antibody-drug conjugate versus chemotherapy was not met. Hazard ratio of overall survival consistently favored sacituzumab govitecan versus chemotherapy in most pre-specific subgroup. There was no significant progression-free survival improvement were also reported in the antibody-drug conjugate group. Sacituzumab govitecan was associated with increased rates of infections in the setting of neutropenia, mainly occurring within the first month of treatment. In summary, there is no universally standard treatment for second line of managing the advanced urothelial carcinoma. However, it is important to take into several factors in selecting treatment options. The real-world data provides important insights into patterns of care and outcomes of second-line advanced urothelial carcinoma patients. Enfortumab vedotin monotherapy has shown clinical benefits in the later lines of treatment. Idafetinib has also significantly extended overall survival in patients with FGFR alteration in advanced urothelial carcinoma. Pembrolizumab can also be used and it has shown significantly prolonged survival independent of PD-L1 expression. With that, I end my presentation. I hope you have enjoyed it. Feel free to contact me via my email if you have any questions. Thank you.